So today's topic is calcium and parathyroid disorders within the endocrinology area. And the agenda for today, this time I am going to give a brief introduction to calcium and PTH physiology, mainly in relation to testing. Then I will go into discussing hypercalcemia with several cases, and then a few cases of hypocalcemia. So I will mainly base the cases on parathyroid disorders and also some vitamin D metabolism. So just to go into calcium physiology, plasma calcium is made up of ionized calcium and albumin-bound calcium mainly. There's also a small amount of complex calcium, but basically half of total calcium is ionized, which is the active component, and the rest is mainly protein-bound, mainly albumin-bound. So when we measure total calcium, we are measuring not just the ionized calcium, but the protein-bound and complex calcium as well. Because the active calcium is ionized calcium, the total calcium we measure is really a reflection of ionized calcium. We want to know what the ionized calcium is by measuring total calcium. Now, the relationship between total calcium and ionized calcium is dependent, among other things, on the pH. So when the pH goes up, so in alkalosis, ionization goes down. So even if the total calcium remains the same, ionization goes down, or more calcium is bound to protein. So ionized calcium goes down, and the active calcium concentration is reduced, and therefore you can develop symptoms and signs of hypocalcemia even if the total calcium is normal, if there is severe alkalosis, like in respiratory alkalosis, for example, in hyperventilation. Conversely, in acidosis, when the pH goes down, like in chronic renal failure, there is more ionization of calcium, and therefore even when the total calcium remains the same, ionized calcium increases. Alternatively, when the total calcium is low, as you often see in some patients with chronic renal failure, the ionization is actually increased due to the acidosis, and it keeps the ionized calcium normal. So as I mentioned, ionized calcium reflects calcium status more accurately because that's the active form. And we found in practice that ionized calcium is more sensitive for diagnosing hypercalcemia and for diagnosing primary hyperparathyroidism. In practice, ionized calcium is not used as frequently for two reasons. One is traditionally total calcium has been used because it's easier, cheaper. Ionized calcium needs ion selective electrode for calcium. It's more expensive and more fiddly, and also sampling and sample handling is important for ionized calcium. Ionized calcium is more labile, so pH changes, as I mentioned, lead to changes in ionization, and we can get a false picture. So it's important to keep the sample cool and also to keep the tube filled to decrease the amount or decrease the degree of post-analytical changes. And also we employ pH correction of reported calcium, so we correct the pH to normal pH, assuming that the pH changes are due to post-analytical changes, although this does not apply if the patient is in fact acidotic or alkalotic. So we really need to correct the ionized calcium to the pH the patient was in, but we assume the patient is patient has normal pH, which is not always the case. So when we measure total calcium and report it, we adjust it for the albumin concentration, because albumin is the main protein that binds calcium, and that's to give a reflection of the ionized calcium, so that the total calcium, or the adjusted total calcium, reflects ionized calcium status better than unadjusted total calcium. And given the calculation, the equation for correcting or adjusting the total calcium based on the albumin concentration, and we adjust total calcium back to albumin of 40, although in the extremes of albumin, less than 30 grams per liter, the correction or adjustment becomes less accurate. So here is an example of someone with a total calcium of 2.0, where the albumin is low at 30. So we adjust it back to 2.20 because the albumin is 10 less than 40, which is what we adjust the total calcium to. So when we look at serum calcium or plasma calcium, we always look at it with PTH, and we need to understand the relationship between plasma calcium and PTH. And here I've given a graph which has plasma calcium on the horizontal x-axis and PTH in picomoles per liter on the vertical y-axis. The lines, the two vertical lines, indicate the reference limits for serum calcium, and it varies between labs around 2.10 to 2.55 or 2.60. And for PTH, again, when you measure it in picomoles per liter, around 1 picomole per liter is the lower limit. The upper limit can be anywhere between 6, 7 or 8 picomoles per liter. So the reference interval depends on the assay and the population. I'll come back to that. However, the graph here is to show the reciprocal relationship between calcium and PTH in normal health. There is a negative relationship between serum calcium and PTH. So when the serum calcium goes up, PTH secretion goes down, and when serum calcium goes down, PTH secretion goes up, because PTH tends to increase the serum calcium, and PTH is the main hormone that maintains calcium balance, and that's how it keeps the balance. So this is the normal relationship, and in health this relationship is maintained. And if this is not seen in a patient, then we know there is an anomaly between PTH and calcium. And if the relationship is broken, it generally means that the parathyroid function is abnormal, and I'll show you some examples. Before we come to that, patient preparation and sampling is important for PTH. As I mentioned before, PTH measurement should always be done with a simultaneous calcium measurement. There is a danger in measuring PTH on its own and then trying to interpret it with the previous calcium, because there's often change in serum calcium, and PTH really should be interpreted with current calcium. Ideally, patients should be fasting, because food has an effect on calcium and phosphate, and therefore to some extent on PTH. There's some diurnal variation, so generally we say measure them in the morning in the fasting state when it's done in a arranged measurement. Of course, in a sick patient who presents to the casualty, sometimes you have to do these measurements whenever the patient presents. The sample for PTH, I prefer EDTA because PTH is more stable in EDTA. So stability-wise, EDTA is preferred for PTH measurement, but some people prefer serum, even though PTH is less stable in serum, because calcium measurement can be done on the same sample. Calcium cannot be measured on the EDTA sample, whereas if you take a serum sample, calcium can be done on the same sample. However, because of sample instability, the sample needs to be processed or frozen within 4 hours for PTH. Otherwise, PTH is degraded in serum. I mentioned reference intervals. Reference intervals ideally should be established for each laboratory, for each population. Just a word about units. Many of the, or most of the American journals refer to PTH in nanograms per liter, whereas most of the European journals refer to it in picomoles per liter, which is the SI unit that's preferred. And if you divide the nanograms per liter by 9, roughly by 9, you get the units in picomoles per liter. As I mentioned, reference intervals should be established for each laboratory. It's very much assay dependent, population dependent, and because of lack of standardization of commercial assays, there can be significant differences. Now, I don't want to go into too much detail about second or third generation PTH assays, but most laboratories nowadays use intact assays, which are second generation assays. Third generation assays, which measure so-called whole PTH, in theory has an advantage because it's more specific to the intact or the whole molecule, but in practice hasn't been shown to be preferred. So either second or third generation assays are acceptable. And for establishing reference intervals, the subjects used should be vitamin D replete and with normal renal function. So when you want to investigate hypercalcemia or even hypocalcemia, the first thing is to sort out the common causes. If you're measuring total calcium, use adjusted total calcium. This can be confirmed if there's an abnormality. It can be confirmed by measuring ionized calcium, or even if an abnormality is suspected but the total calcium is normal, and ionized calcium sometimes picks up hypercalcemia, which is missed by total calcium. Drug history is important in the investigation of hypercalcemia because there are a few drugs which cause significant changes to calcium metabolism. Renal function is important, and then, as I mentioned, measure calcium and PTH at the same time, and then interpret the results. The common causes can be sorted out in most cases, but the rare causes might need more complex investigations. I've listed the common causes of hypercalcemia here. It's found in most textbooks. I don't want to dwell too much on it. The two common causes are primary hyperparathyroidism or malignant hypercalcemia. Some of the drugs which are important to exclude are thiazide diuretics, which retain calcium in the kidneys, lithium, which can stimulate PTH and in the long-term cause primary hyperparathyroidism, and calcitriol, which is the activated form of vitamin D, which can cause increased calcium absorption in the gut. Now, the less common causes, endocrine causes, hyperthyroidism and hyperadrenalism, need to be considered. Less common, but sometimes can trip you up. Excess vitamin D absorption. So, apart from calcitriol, vitamin D itself, if taken in large doses, can cause hypercalcemia. and also pragmatic diseases such as sarcoidosis need to be considered. Immobilization is an unusual cause, but if patients are immobilized, especially in hospital, if they are paraplegic or tetraplegic, sometimes they develop hypercalcemia due to calcium leakage. And of course, chronic renal failure eventually leads to tertiary hyperparathyroidism, biochemically similar to primary hyperparathyroidism. But if you know the history, you can work that out. So the main thing to work out is if there is hypercalcemia, whether this is parathyroid dependent or non-parathyroid dependent. And I've already shown you this graph. And if this graph shows you the relationship. And if this relationship is maintained in hypercalcemia, then that's parathyroid independent hypercalcemia. If the relationship is broken, then there is parathyroid dependent hypercalcemia. If the PTH level is inappropriate for the calcium. So in this case, serum calcium is high. If PTH is also high, then that's primary hyperparathyroidism or PTH dependent. It gets a little bit murky when the PTH is within the reference interval, and we generally say if it's in the upper half or upper 2/3 of the PTH reference interval, this is parathyroid dependent. If it's in the lower third of the PTH reference interval, this is parathyroid independent hypercalcemia. So we come to this patient, the first patient, a 79-year-old woman who presented to the hospital with a fracture neck of the femur, and she was admitted to the orthopedic ward, and during the investigations she was found to have hypercalcemia, mild hypercalcemia. Renal function was normal. She was not on any medication, and she had a PTH of 6.1, which is within the reference interval. So as I alluded to before, if the PTH is towards the upper end of the reference interval in hypercalcemia, we still call it parathyroid dependent. So coming back to this patient, the comment I would add to such results is the elevated calcium should suppress PTH. Therefore, the normal PTH level does not exclude primary hyperparathyroidism. It's not a definitive statement, but suggesting it's likely to be primary hyperparathyroidism. We also mention rare causes of this picture. Lithium therapy can, in long term, lead to primary hyperparathyroidism, like picture. And the other rare condition is familial hypocalciuric hypercalcemia. I will speak on that later. So adjuncts to interpretation of PTH results. So when we interpret the results, there are some points to consider. Now, very high PTH values usually seen in the laboratories in patients who are on dialysis or chronic renal failure. But if they have primary hyperparathyroidism and the PTH is, in our lab, we would say if the PTH is about 30 or 40, then we do say that in our comment, we tell the doctors to consider parathyroid carcinoma. If it's less than 30 or 40, then it's more likely to be primary hyperparathyroidism, benign. Most cases of primary hyperparathyroidism are due to a benign adenoma, but rarely it could be a parathyroid carcinoma, and you should consider that if the PTH is very high. The other biochemical features of primary hyperparathyroidism are a low serum phosphate and due to renal phosphate wasting, and we usually calculate TMP-GFR, which is a measure of the renal phosphate threshold. So if the renal phosphate threshold is low, then there's phosphate wasting, which is what happens in primary hyperparathyroidism. Alternatively, calcium is in fact conserved by PTH action. So in primary hyperparathyroidism, there's urine calcium conservation. So urine calcium is lower than expected for that serum calcium. I mentioned familial hypocalciuric hypercalcemia. This is a condition which is genetically inherited but benign. It just presents like mild primary hyperparathyroidism, and if it's not identified, the patient will undergo unnecessary parathyroidectomy because this is a benign condition and the patient doesn't need any treatment. And in fact, parathyroidectomy doesn't reduce their serum calcium because it's a condition due to mutation of the calcium sensing receptor. So there's a genetic test available, but usually the screening test is urine calcium excretion. And what we do is a 24-hour urine calcium excretion, measure the serum and urine calcium and creatinine, and calculate the calcium creatinine clearance ratio. And I've given the equation there. And in familial hypocalciuric hypercalcemia, calcium creatinine clearance ratio is less than 0.01. In primary hyperparathyroidism, it's almost always greater than 0.01. Very rarely it can be, especially if the patient's on a thiazide diuretic or very vitamin D deficient. So this graph shows you the relationship between plasma calcium and urine calcium excretion, and the normal limits are indicated here. The dotted lines are the 2SD variation, and in renal calcium conservation, where there is increased PTH activity, there is the fasting calcium excretion is less than expected, whereas in renal calcium wasting, for example, in hypoparathyroidism, there is the urine calcium excretion is greater than expected. So I've already mentioned what we do in to exclude FHH, familial hypocalciuric hypercalcemia. Initially, we do a spot urine fasting, spot urine for calcium excretion, which is calcium, urine calcium divided by urine creatinine multiplied by serum creatinine. And if it's less than 30, then FHH is not excluded, and then we go on to do a 24-hour collection, and that way we can usually differentiate between FHH and primary hyperparathyroidism. Ultimately, we have genetic testing for FHH. Again, another graph which shows you the relationship between plasma calcium and calcium excretion in FHH, where the urine calcium excretion is extremely low, whereas in primary hyperparathyroidism, it's lower than expected, but not as extremely low as in FHH. And generally, serum calcium is higher in primary hyperparathyroidism than in FHH. FHH is usually associated with a mild hypercalcemia, with the PTH either slightly raised or in the upper half of the normal range. So to recap, FHH is an asymptomatic benign condition, familial, due to a mutation of the calcium sensing receptor with an increased set point, which causes a reduction in calcium excretion. No treatment is needed, so the main danger is unnecessary treatment due to misdiagnosis as primary hyperparathyroidism. A few other pitfalls to consider when diagnosing the cause of hypercalcemia acute decrease in calcium can increase the PTH. So if someone presents with hypercalcemia with a suppressed or low normal PTH, and the patient is immediately treated with fluid, usually they're rehydrated because they're often dehydrated, and then they're given bisphosphonates to decrease their calcium. The PTH can unsuppress acutely. So the measurement should be done before starting treatment or when the patient has stabilized. Otherwise, you can get an inappropriately misleading PTH. I've already mentioned hypercalcemia with the PTH within the reference interval, not as clear-cut in differentiating PTH dependent and independent hypercalcemia. Now, if a patient presents with hypercalcemia and malignancy, never assume this is due to hypercalcemia or malignancy. It can coexist with primary hypercalcemia. Sample handling is important because if not done properly, it can lead to a lowering of the actual PTH level. Consider monoclonal band or monoclonal globulin which binds calcium, and so that can give a very high total calcium, but ionized calcium will be normal. Heterophilic antibody interference can occur with PTH assays, and PTH assays, like any other immunoassays, can have batch-to-batch variation, so we need to be aware of those. And I've already alluded to the differences between assays, so each commercial assay might have slightly different reference intervals. So there is an entity called normocalcemic primary hyperparathyroidism. It's been designated recently as a diagnosis. So hypercalcemia is generally the hallmark of primary hyperparathyroidism, but there's a small number of patients with normal calcium and raised PTH. So this has only been recognized in the last decade or so. So these are patients who present with signs or symptoms of primary hyperparathyroidism, like nephrolithiasis or osteoporosis or fracture, and their calcium is normal. However, their PTH is increased. And so the diagnosis of normocalcemic primary hyperparathyroidism, it can be made. It's a diagnosis of exclusion. You have to make sure that the ionized calcium is normal, because if the ionized calcium is high, then they are overt primary hyperparathyroidism, and that they don't have secondary hyperparathyroidism. Secondary hyperparathyroidism I will touch on later on. So all the causes for secondary hyperparathyroidism need to be excluded before normocalcemic primary hyperparathyroidism is diagnosed. So the diagnosis, once it's made, then you have to assume that the patient has the risk of developing some of the complications of overt primary hyperparathyroidism. So they're a mild form of primary hyperparathyroidism, and they have to be clearly differentiated from secondary hyperparathyroidism, which is not always easy. We go on to the next case. This is a 52-year-old female with bipolar disorder. So her electrolytes show a very high sodium and high urea and raised creatinine, mildly reduced bicarbonate. You could say that the patient looks very dehydrated. Total calcium is raised, and the phosphate is also high, just above normal. This patient is on lithium, which is used for treatment of bipolar disorder, and her PTH is raised. So this is PTH-dependent hypercalcemia. So how would you deal with these results? So we would say this patient is on lithium. Sustained increase in serum calcium after cessation of therapy would indicate underlying primary hyperparathyroidism. So long-term treatment with lithium can cause hyperparathyroidism or parathyroid overactivity, and often that continues even after lithium is seized, if it can be seized. So those are the two things to make clear to the clinician, that lithium can cause parathyroid-dependent hypercalcemia, and some cases when lithium is seized can normalize, but often they don't, and so they have to be treated as primary hyperparathyroidism. Next patient, a 54-year-old female presenting with lethargy. She has hyponatremia and high potassium, slightly raised urea and creatinine. Again, the patient has got hypercalcemia. PTH in this instance is at the lower end of normal, so it sounds like it's a PTH independent hypercalcemia. So we have to consider causes of PTH independent hypercalcemia: malignancy, drugs like calcitriol, hyperthyroidism, hyperadrenalism, excess vitamin D, and immobilization. And if you look at the electrolytes, it might be a clue to what could be the cause of it. I mean, in malignancy, sometimes patients present with SIADH, but usually the potassium is not raised in SIADH itself. And the electrolyte and the creatinine is raised as well in this case. So we went on to do a cortisol and an ACTH. Cortisol is slightly reduced and ACTH is clearly very high, suggesting that this patient has adrenal insufficiency or Addison's disease, which can cause hypercalcemia. Not often, but it's clearly recognized as a cause of hypercalcemia, PTH independent hypercalcemia, and it's due to inability to excrete calcium in the kidneys, and cortisol is important for that. So once they are cortisol replete, the calcium excretion normalizes, and so that's the cure is to treat the patient with cortisol replacement. 72-year-old man with bone pain and anemia. This should be a spot diagnosis, very high total protein with a low albumin, moderately raised total calcium with a PTH at the lower end. Alkaline phosphatase is normal. So the elevated calcium and suppressed PTH, I mean, it's not totally suppressed, but low normal PTH exclude primary hyperparathyroidism. The commonest cause is malignancy, especially at this age. So we would suggest protein electrophoresis, and now we do serum free light chain measurement to diagnose multiple myeloma, which was the case in this patient. Here's a young man in intensive care unit who was unconscious for quite a long time following head injury, and suddenly this patient developed hypercalcemia. PTH was suppressed, vitamin D is normal, and we also measured serum CTX, which is a marker of bone resorption, and it's very high. This is a typical presentation of hypercalcemia of immobilization. The increased calcium and suppressed PTH is consistent with PTH independent hypercalcemia, which may be caused by increased bone resorption due to immobilization. And we do see this from time to time in our hospital, usually in ICU patients or tetraplegic patients in a rehabilitation hospital if they are totally immobile. the lack of muscle stimulation of the bones lead to increased bone resorption and hypercalcemia, and the PTH is usually suppressed. So anti-resorptive therapy is used to reduce the bone resorption in these patients. So I just want to show you a typical CKD patient with hypercalcemia. PTH is very high. I mean, this sort of PTH is generally only seen in long-term dialysis patients. As you can see, the alkaline phosphatase is also very high, suggesting increased bone turnover. So the increased serum calcium and PTH in this patient with CKD is consistent with tertiary hyperparathyroidism. We don't generally comment on these patients. The renal doctors are quite familiar with this, so we wouldn't comment, but just to show you what in chronic renal failure. So this graph shows you what happens to PTH in chronic renal failure, and the relationship between 125D, the 125D formation in kidney decreases with progression of renal failure, and conversely PTH increases to try to compensate for the lack of 125D. And so in the long term, PTH secretion increases to normalize the low calcium, and then at some stage PTH becomes autonomous and then causes hypercalcemia, which is tertiary hyperparathyroidism. So here is a table to show you the difference between primary, secondary and tertiary hyperparathyroidism. PTH is of course raised in all of them, because hyperparathyroidism means PTH is raised. And in primary and tertiary hyperparathyroidism, calcium is raised. Secondary hyperparathyroidism, calcium is low and PTH is raised as a reaction to the low calcium. And over time, when the parathyroid gland becomes autonomous, then hypercalcemia develops. Now, in long-term hyperparathyroidism, phosphate should be low. So if tertiary hyperparathyroidism is due to long-term vitamin D deficiency, phosphate would be low because PTH increases phosphate excretion. However, in renal failure, the kidneys cannot excrete phosphate, so phosphate would be in fact high in tertiary hyperparathyroidism due to chronic renal failure. I'll just touch on the specialized tests that are sometimes mentioned in relation to hypercalcemia. PTH-RP can be measured to confirm PTH-RP as the cause of malignant hypercalcemia. Generally not necessary, but sometimes it's nice to confirm that strictly not necessary. 125D is said to be increased in sarcoidosis or granulomatous disorders. Again, it's been shown in practice to be not a very sensitive or specific marker. Calcitonin is a hormone which is said to have some effect on calcium metabolism, but generally not measured for calcium abnormalities. It's really a tumor marker for MEN2. I'll move on to hypocalcemia. Causes of hypercalcemia. Obviously, you have to exclude hypoalbuminemia as a cause of a low total calcium. Vitamin D deficiency, obviously, and renal failure. Chronic renal failure is the commonest cause of hypocalcemia in our hospital population. Hyperparathyroidism, not as common, and always exclude magnesium deficiency, because in magnesium deficiency, parathyroid secretion as well as parathyroid action is opposed by magnesium deficiency. So in these cases, if there is magnesium deficiency, then it should be corrected, because sometimes it normalizes the calcium and PTH action. I won't go into the rare genetic conditions which can lead to vitamin D metabolism. disorders or end organ resistance, as well as hyperparathyroidism, which is an end organ PTH resistance. This case is a 56-year-old female. We had this in the clinical history, APFCB syndrome. Some of you would know what it is. I'll come to that. But she presented with a low calcium and a high phosphate, normal vitamin D, but an undetectable PTH. Urine calcium excretion was raised, and renal phosphate threshold was increased, which means there is phosphate retention. That's why there is hyperphosphatemia. So I'll come back to this graph. When the calcium is low, the appropriate reaction is for increased PTH secretion. If the PTH is inappropriately low, then we call it hyperparathyroidism. So in this case, it's clearly a case of hyperparathyroidism. The results are consistent with hyperparathyroidism. Low calcium, clearly low PTH, and high phosphate. APFCB is an autoimmune polyendocrine syndrome which causes hypoparathyroidism. It can also cause Addison's disease, Addison's type of disease, but in this case, this is hyperparathyroidism. APFCB stands for autoimmune polyendocrinopathy, candidiasis, ectodermal dystrophy. So they often have, they always have candidiasis, especially around the mouth area. So this is hyperparathyroidism, clear-cut hyperparathyroidism. In fact, in our country, hyperparathyroidism is most commonly due to iatrogenic hyperparathyroid removal in patients with who undergone total thyroidectomy, where parathyroid glands have been either damaged or taken out inadvertently. That's probably the commonest cause of hyperparathyroidism, but autoimmune diseases can also cause that. Vitamin D deficiency, the definitions are controversial, depends which cutoffs your country uses. In Australia, we use 50 as the normal, though we say at the end of summer it should be more than 50, so that in winter it can be still 50 nanomoles per liter. Again, not the units, it's nanomoles per liter, the SI units. So severe vitamin D deficiency causes osteomalacia in adults and rickets in children. Failure of vitamin D metabolism happens in chronic renal failure, but as I mentioned before, there are some rare genetic diseases which I won't go into. And in vitamin D deficiency, there is hypocalcemia with secondary hyperparathyroidism. Alkaline phosphatase may be raised, and phosphate is low. So that's a difference from hypoparathyroidism, where phosphate is high. So this patient, an 82-year-old woman who lives at home, doesn't go out much, who's weak and has had a fall, question vitamin D deficiency. She's clearly hypocalcemic. Phosphate is low as well. Alkaline phosphatase is raised and PTH is very high. So she's got secondary hyperparathyroidism, and the cause is vitamin D deficiency, clearly vitamin D deficient. And these patients can present with osteomalacia, but more often they present with osteoporosis and/or fracture. They also have falls due to muscle weakness due to vitamin D deficiency. So this comment, we say normal or raised PTH in association with normal to low calcium may occur in vitamin D deficient states, because we don't always see a raised PTH or a low calcium in vitamin D deficiency. We see a raised PTH more often than a low vitamin D, a low calcium in vitamin D deficiency, because the raised PTH maintains the serum calcium at the expense of skeletal health. Now, here is a 2-year-old girl with a history of failure to thrive, and again, adjusted calcium, which is low, not as low as the previous patient, but PTH clearly raised, and the vitamin D, which is clearly low. And look at the alkaline phosphatase. In children, the reference interval is higher, but this level is much higher than you would expect in a girl of this age. X-rays showed metaphyseal flaring and cupping consistent with rickets. The mother had severe vitamin D deficiency when pregnant and was supplemented, but the baby wasn't. And she also had a mild iron deficiency and was treated with vitamin D and iron supplementation. The next case is a 76-year-old male who was treated with zoledronic acid. Zoledronic acid is an anti-resorptive drug which is used mainly for treatment of osteoporosis, which is also used for treating hypercalcemia of malignancy, and in this country Paget's disease. But basically, zoledronic acid is an anti-resorptive agent. It acts on osteoclasts to stop them resorbing bone. In this case, as it occasionally happens, this patient developed severe hypocalcemia following zoledronic acid infusion. We can't always predict who will get that, but sometimes they become symptomatically hypercalcemic. And of course, they develop secondary hyperparathyroidism. And in this case, the vitamin D was normal, and despite that, this patient developed hypercalcemia. Quite a rare complication of zoledronic acid infusion, and more recently, denosumab, another anti-resorptive agent, has also been associated with severe acute hypocalcemia following treatment. It's hard to predict who will develop it. Most patients, when they're treated with anti-resorptive agents, develop mild reduction in serum calcium, often within the normal limits, and often they develop secondary hyperparathyroidism. So we often see patients with secondary hyperparathyroidism with normal calcium who are mildly vitamin D deficient or in chronic renal failure, early chronic renal failure, or on bisphosphonate or anti-resorptive therapy. These are some of the common causes of normocalcemic secondary hyperparathyroidism. Loop diuretic therapy is another cause of this pattern. A 63-year-old female presented with lethargy and weakness. She was found to have a low calcium and a very low phosphate with secondary hyperparathyroidism. So it could have been vitamin D deficiency, but now her vitamin D was normal. Her renal phosphate threshold is very low, which suggests that she's losing her phosphate in urine, losing a lot of phosphate in urine. What we found out was that the patient had a recent iron infusion. This is just to show you an unusual but not totally uncommon complication of iron infusion. So infused iron in some patients cause severe hypophosphatemia and hypocalcemia with normal vitamin D and secondary hyperparathyroidism. And if they have long-term repeated treatments, they can in fact develop osteomalacia. So these patients need a calcium and phosphate therapy. So this is an unusual but well-recognized complication of iron infusion. Some forms of iron are more often associated with this complication, but you need to be aware of it because these patients can develop symptomatic hypophosphatemia and hypercalcemia. This is due to FGF23, which is a hormone that's secreted by osteocytes and causes phosphate loss in urine, and long-term can cause osteomalacia. And you may be aware of some malignant or even benign tumors secreting FGF23, which can lead to hyperphosphatemia. And the last case is a 76-year-old male presenting with hypercalcemia and very high alkaline phosphatase. Magnesium was normal. Vitamin D was checked and was normal, but the PSA was very high, which led to this common comment that metastatic osteoblastic secondaries may cause hypocalcemia. Vitamin D deficiency is excluded. Skeletal imaging studies confirmed metastatic prostate cancer. So prostate cancer is one of the osteoblastic malignancies when it metastasizes to bone, and because of the increased bone formation, it absorbs calcium from blood and can in some cases cause hypocalcemia. So again, not very common, but rare, but well recognized complication of disseminated osteoblastic prostate cancer. So I'll just finish with this table just to show you the different biochemical patterns in different metabolic conditions. I won't dwell on it. I've already touched on all these. And as you can see, in osteoporosis, most of the measurements are normal. You can differentiate hyperparathyroidism from malignant hypercalcemia by the PTH measurement, whereas in osteomalacia you get a low calcium as opposed to high calcium in hyperparathyroidism and malignant hypercalcemia. I'll finish with that. I've got some time for questions. Happy to take questions.
Yeah, thank you very much, Dr. Sam. And, I think I like the new format where there's a little bit more explanation, and this table especially is quite helpful as a cheat sheet. So I must apologize. I think there's some technically some issue with the chat room today, and I'm not getting messages on chat, and I have some colleagues who are just not seeing the chat room as well. So if you have any questions, just go ahead and unmute yourself and ask the question live if you don't mind. So while we're waiting for people to ask their question, maybe I can just ask conversationally, what do you think about this emerging data about vitamin D and COVID-19? Have you been following any of that saga?
Biochemistry in COVID-19?
No, but vitamin D. There's
right. Yes. Yeah. I think the evidence is not in yet, but I think it's reasonable to take vitamin D supplementation as a precautionary measure, because I think there is enough evidence to show that vitamin D may protect against respiratory disease. Now, we don't know definitely that it protects against respiratory disease associated with COVID-19, but I don't think there is any harm in taking vitamin D as long as you take reasonable doses, not massive doses. So 1,000 units a day is more than enough in most cases. So if you take that amount of vitamin D, that's more than enough to be with vitamin D sufficient. We know that vitamin D deficiency is very common even in the tropics because we try to keep away from the sun, so vitamin D deficiency is common. So there is some evidence that vitamin D deficiency may be associated with increased risk of developing more serious respiratory complications of COVID-19. So so there's no harm in making sure that your vitamin D levels are normal. After developing COVID, it might be a bit late in the day to start vitamin D supplementation. Again, there's no harm in if you're not taking vitamin D. If you do contract COVID-19, I would at least start taking vitamin D because there's really no harm in taking it, and there's some suggestion that it might improve your outcomes.
Thanks, Dr. Sam. So just to reiterate, I apologize for the technical glitch. We seem to have some issues with the chat room. So if you have any questions, and please unmute yourself and just ask. You can also, if we happen to be talking and you want to talk, there's also the raise hand feature, and you can raise your hand. Yes, I see a hand raised by Dr. Tuan Sawani Tuan Ismail.
Do you want to speak? Unmute yourself and speak.
I see it's unmuted, but I'm not hearing any audio.
Okay. I might very quickly, if there is, I'll show a couple of slides I had as a backup. But feel free to go ahead and ask questions if you have any. So this is a list of causes of secondary hyperparathyroidism. Briefly mention some of the causes, but decreased calcium intake and decreased calcium absorption are two causes mentioned. Like bariatric surgery is now becoming common, and that can lead to calcium deficiency and secondary hyperparathyroidism, and it can also lead to bone loss and osteoporosis, so something to think about. I mentioned loop diuretics causing secondary hyperparathyroidism, but there is also this idiopathic hypercalciuria. And another rare condition called hungry bone syndrome, when someone has had long-standing hyperparathyroidism, for example, when they are treated, they develop hungry bone syndrome, where they the bone absorbs calcium from the blood, and they become hypocalcemic, and then can develop secondary hyperparathyroidism, but also in refeeding syndrome. Before I go to the next, yeah, go ahead.
Good afternoon, Dr. Vasikaran. It was great listening to your talk. I had a little query on osteomalacia. You said low calcium, low phosphate. And why is it that in osteoporosis it's normal?
Yeah, osteoporosis is quite a different condition to osteomalacia. So in medical school, they used to tell us osteoporosis is less bone, whereas osteomalacia is not less bone, but less calcium. So in osteomalacia, the amount of bone is not decreased. In fact, there is increased osteoid formation, but calcium calcification is decreased. So osteoporosis is multifactorial condition. It can be due to vitamin D deficiency, but it's due to a number of causes. In aging, it's often due to, especially in women, it's due to hormone deficiency. So they actually lose bone. So there's less amount of bone or less bone mass. So it's not a calcium deficiency disorder or even a vitamin deficiency disorder, although calcium deficiency and vitamin D deficiency can contribute to developing osteoporosis. So that's why they have normal calcium and phosphate, whereas osteomalacia is a disorder of mineralization, lack of calcium and phosphate in bone, and that reflects inadequate mineralization of bone, and that's often due to vitamin D deficiency. I mean, that's due to vitamin D deficiency. So they don't absorb calcium and they lose phosphate in kidneys. So they're two very different disorders.
Thank you.
You're welcome. Okay, this is just one last slide I had as a backup. The PTH levels that you see in these three conditions of, that can cause hypercalcemia. In primary hyperparathyroidism, PTH can be in the upper half or upper 2/3 of the reference interval or raised. And this one point, which is above 30, might be, in fact, possibly parathyroid carcinoma. Not necessarily, but you need to look out for it. Humoral hypercalcemia of malignancy, you can see clearly suppressed PTH or at the lower 1/3 of the reference interval. And then familial hypercalciuric hypercalcemia, where the PTH is only slightly raised or generally not suppressed, usually within the reference interval. In fact, there are a couple which seem to be suppressed, which is anomaly. Generally, the PTH is within the reference interval. But you need to be aware that you can have primary hyperparathyroidism with a normal PTH or inappropriately normal PTH in the presence of hypercalcemia. And conversely, there is this new or reasonably new condition called normocalcemic hyperparathyroidism, where the PTH is raised, but the calcium is normal. So normocalcemic primary hyperparathyroidism has to be differentiated from secondary hyperparathyroidism because both of them have a raised PTH and both of them can have a normal calcium. You would assume that if it's in the upper half, or if the calcium is a high normal, it's more likely to be primary hyperparathyroidism, whereas if it's low, then more likely to be secondary hyperparathyroidism. But then you need to exclude the causes for secondary hyperparathyroidism. Okay, if there are no more questions, are there any more questions?
Yeah, apologies again for the technical issue. Sorry. We will send our, if you don't mind, Dr. Sam, I'll kind of review your email so that anyone with further questions after this can send you a question by email.